and in delivery systems that support health. And this webinar series is a chance for us typically to feature a study from our Systems for Action program and a chance to hear about research findings and learnings as studies progress. Today's webinar is a little bit different. We're pivoting a little bit in that we've got a variety of panelists that are with us today that will be talking about what we're learning in the field of in the area of intervening on social determinants of health, particularly intervening at policy and systems levels. Our group of panelists today definitely include grantees and researchers who are involved in the Systems for Action research program, but we've extended that family a little bit today as well, and are bringing in some other colleagues and collaborators who are working broadly in the field of social determinants of health, particularly at policy and delivery system levels. So, so we'll have a little bit of a broader discussion today, kind of abstracting beyond individual research studies and out into kind of the larger field of knowledge and practice about social determinants of health. I'm going to just give you a brief preview of our panelists who will be joining us today. You're going to hear from Dr. Todd Wagner, who's director of the Health Economics Research Center at the Palo Alto VA and also associate professor in the Department of Surgery at Stanford University. He studies health information technologies, efficiency, and value in healthcare delivery. He's one of our current Systems for Action grantees. Another panelist today, Dr. Elena Rosenbaum, who's medical director at the Healthy Alliance New York initiative. She's a physician educator specializing in family medicine and integrative medicine. Also has a license in medical acupuncture, and she's also a current grantee of our Systems for Action research program. A third panelist we're going to hear from today is Dr. Raj Srivastava. I apologize, Raj, and he can correct me on his name. I apologize for that. He's a tenured professor in pediatrics at University of Utah in the division of inpatient medicine, and practicing hospitalist there at the Primary Children's Medical Center in Salt Lake City. Currently working with the Intermountain healthcare system as a senior medical executive director in healthcare delivery, and in that work he is deeply engaged in implementing social determinants of health screening and intervention strategies within the context of a large integrated delivery system there at Intermountain. Then our fifth panelist today, we're going to hear from Dr. Elizabeth Ford, who is a board-certified pediatrician and has served in executive leadership roles at a variety of levels within our health system, local, state, and federal levels. Recently, she served as special assistant to the president for public health and science in the White House Domestic Policy Council. And in that role, Dr. Ford was the principal author of the White House Action Plan for addressing social determinants of health, the social determinants of health playbook developed by the White House. And so, again, has obviously a rich and deep base of expertise in both policy and practice around intervening on social determinants of health. So really exciting and talented panel of speakers today. And just in terms of logistics, we're going to hear briefly from each of our panelists today. We will have time to entertain questions from our audience today. We encourage those of you who are participating, if you've got a question you want to ask one of our panelists, we encourage you to use the Q&A box feature of Zoom. You should see an icon down at the lower section of your screen. You can type on that Q&A box and type in your question really at any time during today's webinar. We'll get to as many of those questions as we can during our Q&A session toward the end of our 90-minute session today. So with that, I'm going to turn it over to our panelists. I think to Dr. Wagner first to get us started.
Great, thanks, Glenn. And great to see you all. It's great to see so many people here today. I've been asked just to say a few words about the economic case for investing in social determinants of health, and I'm going to try to weave together just two threads. First is the reality of the US healthcare system. The US spent approximately almost $5 trillion on healthcare in 2024. Per person, that's about $14,000. For many of us, that's just a staggering sum, and the costs continue to increase. Much of the money is spent on specialty care. And if you didn't know, 88% of the physicians in the US are specialists, compared to, for example, 53% in Canada. So the US spends more on healthcare than any other high-income country, yet not a surprise to many of you, our health outcomes are not among the best. And in fact, they're probably among the worst. So the second thread is about social services. So health is not just a function of medical care. Safe housing, access to healthy, nutritious food, and good, reliable transportation have an undeniable and large impact on one's health. When we consider the health of a population, these social determinants are more important in influencing health than access to medical care and genetics. So I was asked to comment on the economic case for investing in social determinants of health, and that in some sense involves weaving these two threads together. The premise is that greater investment in social services will reduce the amount we spend on healthcare. And the truth is, unfortunately, no one agency is in charge of providing health and social services. Healthcare organizations work to provide their patients with access to high quality care. And similarly, social service agencies provide access to nutritious food, housing support, and transportation. Although both healthcare organizations and social service agencies are interested in improving population health, there are gaps between these organizations. And these gaps, they're real. They can be problematic. Sometimes healthcare organizations make choices that help them manage their budget, although these choices may not be socially optimal. We saw this with substance use treatment programs. Between the years of 2000 and 2010, despite increasing evidence that substance use treatment was cost-effective, healthcare organizations were cutting substance use treatment programs because the returns on investments didn't come back to them, but went back to criminal justice. This is what's known as the wrong pockets problem and what the System for Action has been trying to solve. There are times when we've been able to solve the wrong pockets problem, but in limited circumstances. So for example, getting better nutrition and exercise before surgery results in shorter and less expensive hospital stays and better outcomes. These are known as Enhanced Recovery After Surgery, or ARES programs. ARES programs have been successful, but they've been circumscribed in many regards. Thinking more broadly, we intellectually understand that wrong pocket problems exist, yet how we fix the wrong pocket problems at scale is not at all clear. And let me run you through just a few options. One option would be to fund hospitals and healthcare organizations to provide transportation and food and other social services. However, I would argue that's not a good use of resources. Hospitals are incredibly expensive and highly regulated, and it would be inefficient to have a surgeon or a neurologist manage food delivery or transportation. Another option would be to increase funding for social services. At some level, that might be the easiest, except that it requires increasing taxes and is highly political. And again, that might not be successful, as we all know. And then finally, if healthcare organizations see returns from increases in social services, would they support some sort of alternative payment model where the savings in healthcare are shared by both the healthcare organizations and the social services agency? That vision is what gave rise to Healthy Alliance in New York State, and Elena will speak more on that. We're partnered with Healthy Alliance in an ongoing evaluation with funding from the Robert Wood Johnson Foundation through System for Action, so I'll be upfront about my conflicts. We're trying to understand the timing of the returns. We don't know when healthcare organizations will see a return for greater investments in social determinants. Will investments in social determinants help the hospital or healthcare organizations this year, in the next 2 years, or will it take 5 or more years? As you might expect, the timing really matters, especially if you're an organization trying to balance their budget. And Raj can speak more to the challenges of running a very large health organization with a defined budget. So there is an economic rationale for investing in social services and addressing the wrong pockets problem. But like many things, I think the devil's in the details. So let me stop there and pass the floor to my colleagues and see what they have to say about how we might solve this problem. Glenn, should I pass the baton?
Yes, thank you. I think pass the baton. I think Elena, would you like to go next?
Thank you. Yes, I'd love to introduce the work we're doing at Healthy Alliance and our journey. As Glenn mentioned, I'm the medical director of Healthy Alliance, a social care network and community care hub in upstate New York. I'm also a practicing family physician, and I've experienced firsthand what Dr. Wagner was talking about, the frustrations of not being able to help people because I could refer them to expensive specialists and give them expensive medication, but not be able to really address what was underlying their health issues. So we work with Dr. Todd Wagner and Dr. Shaw and others at the Stanford ESU. Thank you for funding us, S4A, on the study to advance the evidence and the work and understand what is really going to be whether this is a good intervention for addressing social drivers of health through the wrong pocket problem and addressing the wrong pocket problem. So Healthy Alliance journey began in 2018. We were funded by New York State Department of Health District, and a group of leaders that were sitting side by side, healthcare as well as social care and behavioral health leaders, understood that there was a big gap in the community. And they invested in a technologic infrastructure closed loop referral platform as a backbone to connect the different stakeholders and the different organizations together, as well as hired a bunch of team members to support the implementation of the tool and social care screening, as well as making sure that the workflows and that the other work could get done with as little stress as possible for the partner organizations, as well as the community members receiving services. It started in a small region in upstate New York and expanded up to 25 counties. And by early 2024, we had above 450 organizations, over 2,000 programs across 25 counties, as I mentioned. And we now appreciate CMS and the New York State Department of Health in working and to approve the 115 waiver that sets up social care networks across the state. And we've been designated social care network in Central New York, in the North Country and Capital Region. So I just wanted to mention some of the things that we see as some of the value of using a social care network or a community care hub in a community to help integrate health and social care. We have the ability to facilitate contracting for MCOs and healthcare organizations across a suite of services, not just individual programs. And that's important because we can treat people holistically, because we know that health-related social needs coexist. We also support and help meet the health equity measures and regulatory requirements that are coming up for the healthcare organizations and MCOs. And we have teams, as I mentioned earlier, that support the work so as to decrease the burden for the workforce. For the CBOs, the social care network really functions as a back office to support training, billing, contracting, all the compliance requirements such as privacy data. And they can stick to providing services in the community. And for community members, at the end of the day, this is the most important value that we need to look at, is the network provides no wrong door access to screening and service connection. And the hope is that the navigators reduce the stress associated with navigating the complexities of healthcare and social care services. So I think, Glenn, we were going to talk about, I don't know if you want to introduce the others. And thank you.
Yes, let's bring on another member of our panel. I think, Raj, would you like to go next? Give us some initial thoughts on this area from your vantage point.
Yeah, that'd be great. And then I did want to just share some slides. Can you see those? Okay. I know everybody else is talking. I'm a visual learner, so I didn't know if some odd almost 300 people are as well on the call. So it's Raj Srivastava. Glen, there's no presumption I had that you would be able to pronounce it. At the hospital, people just say, or my work Raj, or at the hospital, Dr. Raj. So anyways, look, I just want to speak from the point of view of why does a healthcare delivery system care? And I just love the two previous speakers, Todd and Elena, talking about the work, because it really matters to the patients and the communities we serve. So, we are like a lot of other health systems. We're a collection of hospitals, clinics, providers that are getting together to really provide healthcare. The thing that makes Intermountain kind of interesting, and I've been here for 23 years, I've been trained on the East Coast, was there are a couple things. One is we have a health insurance plan that started in the 80s. And the health insurance plan was started because the other insurers, the big commercial ones, were outpricing what the community needed. So Intermountain was about 20 years old. It's 50 years old next year. And it was asked to create a health insurance plan by the community to at least keep the costs low. So that really went into the mission of being there for the community. The other thing that is kind of unique about Intermountain is, just like many health systems are on this value-based care journey. So instead of transactional care, fee for service, so you come see me, I order an X-ray. Because of the X-ray, I make a little extra money on the X-ray. Value-based care is, wait, it's predetermined by the insurance company to pay a certain amount for the patients. And then the health delivery side has to deliver all the care, should be super high quality care that we all expect, but gets paid up front. And so it really changes the nature of the game. I don't get paid more if I get an X-ray as a doc. Now we're supposed to be figuring out how to keep the community healthy. It's a very different payment model. Intermountain, for every dollar, I put down our revenue that we get, 37 cents is a value-based payment. That means there's about $5 billion that January 1st comes into the health system to care for the patients. Now look at the health insurance plan, 1.1 million members. Many of those are facing social determinants of health or social drivers of health that are not, that are very challenging for them. So if the insurer and the delivery side are aligned to care for the population where they are more so in our system, then we really have to partner in novel ways. That's why, Todd, you were talking about the economic piece, and Elena, you were talking about the ways you're connecting. We want that too. And so what that led to was a super fascinating project where our board chair, some of you may know Mike Levitt, he was DHHS secretary under Bush. He's now the board chair of Intermountain Health. And he actually came to our fourth CEO, Mark Harrison, and said, Mark, I don't think we're doing enough for social determinants of health. Apparently this is true. I heard this from Mark. They were in a cab ride and they were riding back together. And so Mark said, you're right, we're not doing enough. And Mike Levitt said, okay, I want you to spend some money and figure out how to do this better. And so they agreed in the car to launch an experiment, kind of taking a lot of the principles, Todd, you were talking about, and saying, how do we create the Utah Alliance for Determinants of Health and take two geographies within Utah that, by the way, if you look at their outcomes, and Utah's not that big of a state. I mean, it's beautiful, it's big, it's got great skiing and, national parks. So sorry if I misspoke there, but it's not massive in terms of geography. And within two counties, the life expectancy was 10 years different. 10 years if you were born in 2000. Kind of nuts. So we picked those two counties and ran this $12 million experiment where we basically put together community-based organizations, the health systems, health plans, federally qualified health centers, and said, look, let's just screen everybody. And then let's figure out how they need help. And so we activated community health workers, and then we had digital platforms. And then depending on the results of the screening, we would give care. And so this is, I just shared a little bit of data, and then after we can send out the publication list. So Intermountain over this 16-month period saw a little over 2 million people in the primary care and emergency departments. We screened 375,623 people. Most of them were adults, and some of them were kids. Yes, I'm sorry, the icon shows like, why does that kid attach the adult? I actually was not that good a few minutes ago when I was changing the slides and updating them, but bear with me. So we learned a lot of different things, which I'm happy to share. But the piece of it is key is health systems want to do this. We need to do it in partnership with experts like that are on this call and others, because this is not a one group can solve it. I think Todd mentioned earlier, this is really complicated. Well, now the health systems are getting involved because guess what? It is amazing to be aligned in your business model to keep people healthy. So if you ignore, now social determinants of health are top of mind, just like screening for hypertension and heart disease and all the other stuff. Okay, with that, I will turn it over to the next speaker and stop sharing.
Fantastic. Thank you, Dr. Raj. And I now want to give some space for our fifth panelist, Dr. Elizabeth Ford, to make some introductory remarks about her vantage point on social determinants work.
Sure. First of all, thank you so much for having me today. I would like to actually start with a story. So as a pediatrician, after I finished my training, I worked at a free clinic in East LA. I'm bilingual, so we didn't have a language issue, but I had a child who kept coming back over and over again with the same ear infection, despite having free care, despite having free medications, and a bilingual provider. Well, on further investigation, she and her family were living in someone's garage. Those of you with children and those of you who are docs know that amoxicillin has to be refrigerated to be effective. So we could have doctored her for years and literally changed nothing because, in fact, her issue was social. And if we had continued to doctor her, we probably would have made things worse. So here we are 20 years later, and the only thing that's changed is that we now have a name for this. At the individual level, we talk about basic needs, but when communities have the same basic needs, you're talking about the social determinants of health. All the insulin in the world is not going to help an unhoused diabetic or a diabetic that's food insecure. Free clinics only serve when we can get to them. Inhalers and nebulizer machines are great, but if your apartment is filled with mold, you're still going to end up at the hospital. So again, we're not going to doctor ourselves out of the healthcare crisis. More emphasis, more investments need to be placed on non-medical issues that keep people from being well. It was mentioned that I helped to draft the U.S. playbook to address social determinants of health. Well, first of all, that was with a group of extraordinary people across 30 different U.S. agencies. Initially, what we were trying to do was link the healthcare system, public health, and social services in a way that made sense. The final product, which should be, the link will be included in your materials, it is looking at 3 specific pillars. The first pillar, which in my opinion is probably the most important, is data integration and interoperability. Most social service agencies and healthcare agencies and hospitals are probably serving the same population. But because we don't have data sharing flexibilities or permissions, we're repeating care, or we're requiring citizens to go to 7 different agencies to get services when we know that if you're unhoused, it is highly likely that you are also food insecure. So why is it that we have to go to several different agencies to get the same care? So I feel like the data interoperability, the data connectivity will help us to share the information across agencies, because one of the Biden administration's executive orders really spoke to the fact that we need to make things simpler for folks to access care. So that's pillar 1, is data interoperability, data integration. Second pillar is funding flexibilities. I'm an old public health folk, and grant writing is an art. It is, if you are lucky enough to get a grant, that's job one. But number two job is the flexibilities to use the money for what truly needs to be used for. Most grants do not allow you to feed folks or pay for transportation, yet they have a community engagement requirement. And so if we're really trying to meet people where they are, we're gonna have to be a little bit more flexible in how we are allowed to spend funds. The third pillar of the playbook is funding and support for backbone organizations. Backbone organizations are those community-based organizations that really do all the work, honestly, but are usually struggling grant to grant or philanthropic measure to philanthropic measure to keep the doors open. We were trying to figure out ways to keep them sustained in between federal funds or other types of funds so that they could continue to operate. What's happening right now is that community-based organizations are ramping up, they get their work done, and then as the grant starts to run out, the staff leave because they know they've got to find a new job. So what we were trying to do with policies and interventions is create ways that we can have sustainable community-based organizations and improve the linkages through the data interoperability, and make sure that the hospital system and the public health system were engaged, because these are the doors, to speaking to wrong door, that people are coming into. And so if we can figure out a way to connect folks, we can serve the same population, but so much more effectively. So when we talk about investments, maybe we don't need more money, maybe we need to redirect the money that we currently have. Thanks.
Fantastic. Thank you so much, Elizabeth, for those comments. We've gotten some great insight from all five of our panelists to start us off. As the moderator, I'm going to try to dig a little bit more deeply into some of the issues that have been raised by our panelists. And I think I'm going to start, Elizabeth, just with one of your last comments and see if I can probe a little bit more. You talked about the importance of the backbone organization as being a critical pillar for addressing these gaps and fragmentation that we see across our health and social service systems, for addressing the wrong pocket problem that Todd mentioned in his opening comments about the economic problems, economic barriers to doing this work well. So my question is, where are we with getting sustainable support together in this country for backbone organizations? Do we have a plan? Do we have policies that are moving forward that are directing resources to those backbone organizations? And where are the remaining gaps in kind of fulfilling that part of the playbook?
You know, I think that really is the pillar that's the most lacking. I think that the data integration and interoperability is the most challenging, but people are at least working on that. I think there are some great, exciting things coming down the line as it relates to funding flexibilities and grant guidance. But the support for Black backbone organizations continues to be a challenge. I think that we've just, there's so many different types of backbones. The reporting structures for funding can be a challenge to a small backbone. And so I feel like that's probably the bucket of the pillars that really is the biggest challenge, but the most important, because they really are doing a lot of the work.
That makes sense. That makes sense. Elena, if I could bring you into the conversation, the work that you all are doing in New York under the Medicaid waiver authority is really, really exciting, and kind of one of the kind of core pieces of the S4A study that you all are working on. I wonder, can you say more about Medicaid waiver authority, and kind of what solutions does that bring to things like trying to find funding for backbone organizations, or another pillar Elizabeth mentioned, just greater flexibility in funding to be able to invest in the right kinds of services? How much do Medicaid waiver authorities help, and are there still remaining challenges?
Thank you. And Dr. Ford, absolutely, I think around the country, different communities are solving their gaps in SDOH integration in different ways. I think in some communities, the backbone organization has yet to be identified and yet to be funded. We're very lucky in New York State because the 115 waiver essentially funds backbone organizations. The social care networks function as the backbones in New York State. And there's regional social care network entities that have been designated in the last, since August. What this addresses is the startup funding issue that you mentioned. We have funding for investment in the technology as well as the human infrastructure to get the work done, as well as CBO capacity building and training for the network, because that's a huge element of this work is that there's a lot, it's not just about bringing the technology, it's about how to support organizations in being able to identify health-related social needs and being able to work with their partner organizations through referrals. So that's been a real success in terms of sustainability. We were seeking MCO contracts through our IPA that we formed previously. And that was really difficult because MCOs have been investing in maybe single individual contracts at a time for certain populations, but the evidence, big programs that address social care to scale was lagging. So in this waiver, we have the health plans involved right away, developing the processes and involved in the system creation, so that hopefully with the data and the outcomes we get from the waiver, they will see the benefits to all lines of business, as well as ongoing after the waiver. There's other challenges if you want, if there's other things as well. The other thing that we've identified is a single required referral platform in a region. And that's really important because with healthcare, we've seen fragmentation with the electronic health records and lack of interoperability. We're hoping to create, we're really creating region-wide networks that are open to anyone, because the vision is at some point, regardless of health plan, regardless of PCP, age, gender, you can get services through this network. We're not there yet. We're starting with Medicaid, but we're hoping that this region-wide network will facilitate this kind of work.
Fantastic.
Can I jump in quickly?
Please do. Please do.
I love the regional platform, and that's one of the big challenges is this whole platform issue. Who's the best platform? But deeper than the platform issue, what we were finding in our different discussions as we were pulling the playbook together is that even when you have the platform, okay, great, you're doing the linkages now, but to your earlier point, a lot of these smaller org backbones don't have capacity. And so now you've overwhelmed them because the need is tremendous. And so you've got 2,000 referrals, but you've got 40 slots. And so while we're working on the integration piece and the platform, we also need to make sure that we're supporting these agencies, and that's back to the backbone organization support. And so that has to come through 1115s. And I'm super excited about those, although they're super challenging to get also. But once you get one, you're golden. So I hope to see more of those come out in the future. Thanks.
Fantastic. Thank you for those comments. I want to see if we can bring bring you into the discussion here. Really exciting to hear about the work that Intermountain is doing in this space. I wonder if you can add some more depth to the discussion in terms of Intermountain's experience with addressing some of the challenges that we've been talking about, challenges of sustainable financing for backbone organizations, challenges associated with getting enough flexibility and funding to kind of let the dollars flow to where the kinds of services that are needed. What's been Intermountain's experience in this with some of these challenges so far?
Yeah, thanks, Glenn. I think these are really real challenges, and really, it's going to be a collective learning, and it is going to vary by, I think, location, depending on where your funds flow are. In our experience, the reason we got a foundation fund for $12 million to try this, because we didn't want the lack of funds to stop. And so we were like, hey, how do we stand this up? How do we do it? The goal of the funds, though, were to actually give them to the communities. So they weren't meant for hey, what does operations need to start a screener and get the docs to do this, or we're going to pay doc providers or what? None of that. It was all for the community. So a lot of communities joined together to say, hey, we want to partner with Intermountain. Some were used to that, some were new relationships, existing relationships, to say, hey, if there's a social driver or determinant that's discovered, how are we going to connect folks and how are we going to do that? Some of the funds were used for community health workers because that wasn't something we had enough of. I don't know if anybody feels they do, but that was something that was used for. But then the funds were really for the community. So there was a board that was convened where the community were actually co-chairs of the board. So they determined the use of the funds. I'm going to tell you something that's going to be a little fascinating. One of the lessons learned. People didn't use the money for 8 months. For 8 months, the 12 million kind of sat there because people were like, well, now that we've connected, now that we have a platform, now that we're screening, we kind of broke some barriers. So now, there was an agency saying, we're ready to do this one thing. It's great. We're getting more referrals to do it. And that's really why we exist. And so for a while, it's not like anybody was tapping out saying, we're full, we don't have enough. It's just that we needed to implement this and figure out where things were. And I also think people aren't used to having funding. Like, well, what's this for? And is it real? And, the board really had to do a lot of trust building that this is real. You can use it for what you need. So I'm not sure, Glenn, I'm not really adding to Elena Elizabeth's amazing discussion of the national landscape and how complex this is, which I believe is true. But I just say, don't count the health systems out. We want this too. And so this is not going to be a one-stop shop solution. I guess that's what I would add, Glenn.
Very, very helpful. That's great to hear that experience on the ground. Todd, I want to invite you back into discussion as well. You kicked us off by talking about both the economic rationale or economic imperative for making this kind of alignment work around social determinants happen, but also some of the economic barriers to making this work, this kind of collaboration work in terms of wrong pocket problems and related issues. I'm curious about your thoughts, kind of based on the larger discussion. How close are we now to resolving some of those economic barriers to collaborative, responses to social determinants, like wrong pockets? How close are we to resolving wrong pocket problems through some of the strategies we've been talking about today?
Well, that's a tough question. So I think in extreme emergencies, we're okay. So let's just look at the recent hurricane. FEMA comes in and really provides a backbone, or at least we hope it provides a backbone for communities in need through Georgia and Florida and North Carolina to sort of fill some of those gaps, but it's short-lived, right? The money eventually disappears and there's very little tracking of is it completely equitable in where those resources go? And then we've got some money that goes through healthcare systems. I mentioned the ARIS, the surgery component, and Raj has mentioned some other stuff, but again, those are pretty narrowly focused. And one of the things that struck me as I was reading through some of the questions from the people asking questions, so please keep submitting your questions, they're great, is this idea that we've over-medicalized social determinants of health or social risks. And I guess my philosophy is that the US is spending enough money on healthcare and social services, maybe it's not the right allocation of money. And so one of the reasons for bringing healthcare in here, one, is that I think healthcare organizations want to participate. You heard Raj. Maybe not everyone wants to. I do a lot of work with the VA healthcare system. They really want to participate. So I don't think it's just Intermountain. And then two, there's a lot of money going into healthcare. And so it's an obvious target because you're saying we're spending so much money on healthcare, we're not getting the outcome. So why wouldn't we want to try to make that more efficient and redirect it? So I think the challenges, though, on all of these things, it's like trying to shift a giant aircraft carrier. It's got a lot of momentum. These are all big agencies, whether it's criminal justice or healthcare or education. It's hard to bring them into alignment very quickly. And so that just takes time. It takes creativity, people like Elena to come together and say, how do we do this? How do we work at a state level? And what I'm seeing is a lot of really cool innovation at the state level, maybe because the relationships make it easier to work at that level. Same with Intermountain. You can sort of figure out, okay, in our region, how do we make this work versus like, how do we do it at the nation? We seem to be sort of in a gridlock in the nation with politics right now. So it's really hard to make major national efforts.
Good points. Good points. We are getting some really good questions being submitted by audience members. We're going to get to those in just a moment. Before we do, before I let go my reins of the moderator directed questions, I want to see if I can ask our panelists. You're all coming at this work from a variety of different perspectives. I want to make sure you've had a chance to tell us the most exciting or most promising innovation you've seen in this space around addressing social determinants of health, something that you're particularly excited about, a strategy, a policy, a potential solution that that you'd encourage us and our audience members to keep their eye on. So any nuggets you want to identify in terms of promising strategies in this space that we should be keeping our eye on. Not to put anybody on the spot, but Elena, you have any thoughts on that front?
There's a lot of really great work happening around the country. I think at the state level through 115 waivers and locally, there's lots of innovations that are happening, like basic income projects. There's work looking at both community level and individual level interventions that are getting piloted, that they're thinking of piloting. And I think all of these will be really important to look at. I think right now, the work that's interesting to me is seeing how all the policies from all the different and all the regulatory requirements are really converging. There's a lot of movement towards health equity from CMS and from other payers. And I think there's the benefit of that is that there's a lot of momentum. The challenges are around alignment, making sure that the programs align and that we're not having different workflows, different processes, and that the work we all do is really visible, as Dr. Ford mentioned, with the interoperability and the data visibility, because we have the chance right now to converge all our efforts towards one goal of addressing health-related social needs. And if we do it right, we can support whole communities, and we can avoid some of the, overscreening and some of the other things that could happen if we're not really careful with alignment.
Very good points. Elizabeth, is there something that you're particularly excited about, a new strategy or development in this space that you'd encourage us to keep our eye on?
There's a lot of excitement to go around right now. I think just the increased awareness around this issue is super exciting. We've seen some changes coming down the pike, as I mentioned, about grants guidance, which I think will be a game changer. Seeing these 1115 waivers coming through with more innovative ways to use funds, I think is super exciting. And the more successful these 1115s are, then our goal, hopefully at some point, is to put them into policy. I think also I'm just excited about the fact that people are understanding that this is not just an HHS issue. This is not a health. I mean, this is a DOT issue. It's a HUD issue. It's a labor issue. And so that's why we were so excited to pull together the playbook with non-traditional folks in the mix, because this really is an everybody problem. And so once you get people that are sort of outside of your comfort zone working on this, I think you see a lot more forward momentum. So that's very exciting for me.
Fantastic. And Raj, anything that you see that have you particularly excited about new developments or new directions in this area?
Yeah, Glenn, can you hear me? My internet cut out for a second. Okay, yeah. Look, I think I love that there's so many people on the panel who have such a national view of this, because it is so important. And I love that last comment, Dr. Ford, about the it's not one person's issue. It's everybody's issue. I'm excited that health systems want to be in the game, because I agree with Todd. That is where dollars flow. Having providers, you do interact with people. That's not the only thing. So I don't want to make it sound like over medicalization. That's not the intent. But if health systems, especially if they're value paid, they can do things that you can't do on fee for service. So I would say watch what health systems are doing, not just Intermountain, although there's this really cool housing initiative where, developers want to raise some ground and then build an amazing condo in Salt Lake City. But Intermountain with a group says, no, let's buy it and do some low housing for low income people, and then keep people housed until they can get something more permanently. So there are like 6,000 people who have gone through that, including families. Like, you got to be innovative, and health systems want that. Now that you've aligned financial incentives, that is going to be, I think, one of the things to watch for. So it's not just Intermountain. I know many other health systems are trying to do this. So I think I'm just excited, Glenn, is just keep us in mind. Then I'm going to have to apologize, Glenn. I have to go give a talk at another national meeting. This was amazing. Thank you for including me. Really appreciate it. And I'll keep an eye on the chat if I can answer some other things.
Absolutely. I knew we were going to lose you a little bit earlier. And if we have other questions for you, we can follow up via email. Thank you for being with us, Raj.
Yeah, thank you, Raj.
And Todd, I'll give you also a crack at this. What's new? What's got you excited about new developments in this space around social determinants interventions, and anything we should be keeping our eye on?
So I have to say, I love my job. It's that I'm always learning, and I've been focused on healthcare almost exclusively for 30 plus years. And so this research project has really opened my eyes to social service agencies and all they do and the complementaries between health and social services. So that's been super fun. One of the amazing things is it's just how much they do with so little resources. And it just blows my mind when I see all the stuff that's happening locally with all the social services resources. And if I were to put that, as one of the commenters said, medicalized, it would blow up. So what I'm most inspired by, most scared of, is how we scale local learnings, what's happening in New York and individual communities nationally. And I think there's got to be tremendous opportunity, both on a tech side, like how do we do it, as Dr. Ford said, the interoperability of these things, but there's just human connections here that are really tough when you're working in a small community and you realize that there's some agencies that are doing X, Y, and Z. You have to think about what is the contracting mechanisms that align those in the healthcare, and there's thousands of those contracts. So how do we think about efficiently creating those contracts, making those work? To me, that's like really tough, but super, super inspiring. And I'm amazed what Elena and her team have been doing to try to make this work. So for me, it's just a humbling experience to be along for the ride and get to pull my statistical resources to these things.
Fantastic. Well, we are definitely grateful that you are in this field and one of the key innovators and researchers in this space. I'm going to ask one final moderator question, and then we're going to get to our audience questions. I'm just, since we are a research program, Systems for Action, and a big part of our mission is really kind of to empirically test these innovations that are occurring that have been designed to address social determinants of health. So I want to ask all of you, from your vantage points, where are we in terms of building evidence around effective strategies to address social determinants of health, and specifically, what are the biggest still remaining gaps in evidence, scientific evidence about these strategies that we need to fill? Any one of you, welcome to jump in on that with your thoughts on that, the scientific evidence behind these strategies.
Well, I don't know about the scientific evidence, but I definitely think economically we need to show ROI. That's part of the reason why this is such a challenge right now to get investments, is because we're starting to find evidence, and it's getting published that if you do these interventions, we do see down the line improved outcomes, which ultimately results in less cost. But it was thought that, when folks first started talking about SDOH, this was just some more money we had to pour into something that may or may not be helpful. And so when we have health economists on board that are actually showing, the benefit of this, that's when people start to pay attention, because everybody's trying to save healthcare costs. So if we can continue to gather information, gather data that shows, confirmatorily that this is a great way of investing, because we keep pouring money into pipelines to train docs, but as you said, most docs are specialists. So the folks that we may be investing in training may or may not be serving the communities that need them the most. So I think we need to just figure out ways non-clinically to improve healthcare and outcomes. And so finding out the financial benefits of this stuff would be a game changer.
Fantastic. Thank you. Other thoughts?
Yeah, I mean, one of the commenters is bringing this up, and I'll just address it. There's a bunch of tax policy out there that works. So you could look at the earned income tax credits and their effect on poverty and so forth. Where I'm struggling with right now, and I've sort of, you go back and forth through these things of decades, and you feel like everything that is being discussed at a national level just gets mired in gridlock. And so I find that frustrating. It's very inspiring to see what the local states are doing, but in some sense, I would like to see it at the national level, but I have a harder time arguing for we need X, Y, or Z, because it seems to get very non-partisan or partisan very quickly. And so I do want to say that tax policy really does matter here, though. I just don't know if it's an easy lever we can move.
Good point. Elena, your thoughts?
Yeah, so, I think the data for individual vertical programs that serve certain populations is growing, right? The evidence and the ROI. And so that you've seen some investments in things like food as medicine and other programs through in this way. I think the horizontal set of services, the network, the ability to really address a whole set of health-related social needs, that data has been lagging. And now there's some beginning pilot data from the Healthy Opportunities pilot in North Carolina, and hopefully, and we're working on this study that looks at a network set of services. And that, I think, will really inform, these types of investments moving forward. Because part of the medicalization is that we're looking at the sickest people, really, and trying to find ROI because it's short-term ROI that you can find. Whereas those that are healthier, those that we have to invest in, like through that's some of the work that Dr. Wagner is talking about with the child, the tax credits and all of that. That's really impacting. Like, we want to look at what happens. How can we prevent the illnesses and diseases from happening in the first place? And those investments have to happen early for young families and people before they're sick. But that's going to require longer term ROI, I think. I mean, I'll ask the health economists on the call, but I think that's a harder ROI to get, at least from my perspective. But I hope I'm wrong. I hope that Dr. Wagner can.
Well, I think it is either you have to really be careful in how you target and really identify people at very high risk and target them, or you have to have a long range sort of horizon that you're willing to wait over. And unfortunately, I think it's human nature that we don't like to wait.
Very good points. Really, really helpful perspectives on this that we will keep an eye as we move forward with systems for action and related research initiatives. So we are down to our last 20 minutes of our webinar, and I want to devote this time to the great questions that have come in from our audience members. We're going to get through as many of these as we can in the next few minutes. We'll start with a question from Jacqueline. She's asking, what's the biggest barrier to improving social determinants of health in underserved communities right now from your perspectives? Anyone want to give us your thoughts on the biggest barrier?
Well, I'll start. The lack of coordination. As I said, we're all serving the same population for the most part. And so the inability to share data requires people to do much more work than they should have to get the services. And so if people get frustrated and just don't go, or, you know, they get caught up in the bureaucracy, where if I just say, hey, I'm sending all your information over to this agency, they're going to call you and set up a time that's convenient for you to have a telephone conversation or video chat. You don't have to come through here. You know, those types of, all the bureaucracy is what makes it tough, and all the lack of integration of the data. If we're not sharing the information, which would make things so much more simple.
And just to highlight the data problems, because it didn't dawn on me when I was working in healthcare until I started working with Elena. We're trying to merge records from social service agencies and healthcare data, because that's how we're going to understand the value proposition of this. The social services agencies, I'm expecting them to have like social security numbers, names, date of births, and they're like, well, we have a name. We have an address. We think it's right. And that's how we deliver the social service agency. But from a data science perspective, where I need precision to make the merge, that's really hard. And so just as Elizabeth's talking about this interoperability, it's sort of like, you know, our desire for privacy and sort of for keeping these things separate is also our challenge in building an evidence base that allows us to say, is this really helping people? And so that's a challenge that I'm continually facing. I would just love to just be able to go into a data sandbox that people are building and say, how do we pull these different data systems together, pull in IRS data, and you can imagine a way that you could do it with a trusted partner so that, you know, data aren't getting out, but that would really allow us to build an evidence base for this. But that's right now, that's almost impossible. So yeah, thank you, Elizabeth.
Very good points. Another question or comments about the risk of over-medicalizing our strategies around social determinants of health. And we've talked a little bit about this in the discussion so far. I wonder if there's more to say. Is that a problem in some of our social determinants of health strategies, and how can we avoid a tendency to medicalize our responses to social determinants in this kind of work?
I can provide a little bit of thought into this. So, you know, you think about food as medicine, it's a great program, right? You can support people with their health needs with food, but it's a short-term service, really. And it really doesn't address the, you know, there's still the underlying food access issue when the food as medicine program is over. I mean, you can sign people up for SNAP, you can optimize WIC and all the other programs, but there might still be food insecurity. And so I think there's a real need to think about, like, how do we support the whole population? How do we support everyone with these needs? And then how do we layer on any kind of medical, you know, like more specialized medical intervention? But what's happening is that even in New York State, where we're going to have funding for health-related social needs, we're having very tight eligibility criteria for who can get the services. So every Medicaid member will get screening and navigation to state, local, and federal programs that are existing. And paid services will be available for some small group, for a group of managed Medicaid who have certain conditions. And so again, part of that medicalization is because we're funneling, you know, we're providing these services only to certain folks that have these health issues. So I think we need to think about as a country and at the state level, like Dr. Ford talks about the whole government approach, but how can we really optimize, prevention?
Excellent points. We've got a couple of questions that are a little bit more narrowly targeted to the Intermountain work. And so we're going to save those and forward those on to Raj and try to tackle those after our webinar today. But a more general question asked about the role of the role that payers can play in helping to resolve and unmet social needs of the patient. So I wonder, and I know Raj could weigh in on that one as well, from given his position at Intermountain. But our other panelists, are there more that we can say about specific roles that we'd want to see payers play in this space?
I think that's directed at me, Glenn, as the health economist, but I welcome comments. So there's been a lot of interest over the past 10 years, longer historically, on value-based payments. And, the folks at Penn, Rachel Warner and folks have done some great work to try to summarize that. A lot of these issues, we struggle to see meaningful changes. So pay for performance was a vogue thing 15 years ago. And what we realized is it took a huge payment to get a performance boost that we thought was worth it. And so that sort of fell by the wayside. What we're coming up now with is this idea of there's really got to be sort of shared wins between systems and payers and providers. Or you have systems that are much more like Intermountain or Kaiser, where they're paid per member per month. And that doing so makes them sort of focused on, in the ideal scenario, sort of best outcomes of the patient. Now, of course, there's some challenges therein. Patients cycle in and out of health plans, and so that may not always sort of materialize. But it's great working with Intermountain. I like working with them. VA is a very much similar per capitated payment. And I think that keeps sort of value in the fore. I think one of the things we're seeing with Medicare now is sort of the push to try to move more people into managed care. Obviously, with Medicare, that's happened very quickly. So I think more and more of these discussions will come up about, are we generating value-based payments? Can we actually improve this? And then eventually it's going to be, is it the right set of services? Is it things that are medical, non-medical? How do we support the non-medical?
Excellent points. Related questions come through, recognizing that we've been talking a lot about healthcare system stakeholders, particularly with regard to this wrong pocket problem that you raised, Todd, earlier. And the question is, what about other pockets that may benefit from effective social determinant strategies, and how can we engage some of those other kind of stakeholders and resource controllers outside the healthcare system, like law enforcement, courts, corrections, employers, education, other sectors that might benefit or might save money if we implement effective social determinants strategies. Any thoughts about those sectors and how to get them involved?
Yeah, I mean, that's why we were so intentional about including other agencies in the playbook, because, this isn't just HHS. And at first everyone, oh, HHS is working on it. Well, no, but Ed needs to work on it too, because that's where our kids are. And the same issues that we're dealing with chronic diseases in our adults are impacting our kids and impacting their ability to be successful students. And so you think about that, you think about housing. How do we, keep housing safe? Because there's issues with mold and issues with all sorts of different things. And so law enforcement has a role in that. Domestic violence and safety is a social determinant. So how do we make sure that people are living in an environment that's peaceful enough for them to worry about their health? On Maslow's hierarchy, sometimes health is down at the bottom when you're talking about food and housing and safety. And so, it's important to have these other agencies there, because first of all, their perspective is different. Their resources are different. And sometimes they have ideas that we've never thought about because they're looking at it from a totally different lens. So I think, the more different opinions you get on how to fix things, it always works out better.
Just to amplify a little bit what Elizabeth was just saying. So I was in Denver this past weekend at a conference, and they were talking about integrating mental health services and how to implement that for kids in schools. And so some of the numbers they were putting up looked reasonably inexpensive, the ballpark of $100 and something per student. And that sounds pretty inexpensive, at least from my hat, from the healthcare world. But then I'm reminded that, we just started the school year here in my hometown, and there's calls going out for parents to bring in paper and pencils. And so at some level, there is also this disconnect between how do we keep the schools functioning on a sort of zero budget, and how do we do what we think is a relatively inexpensive thing that's really valuable, which is sort of integrate some basic mental health services into schools that we also value. And where I'm struggling is, like, what are we willing to give up to get that? And I don't have the answer to that, Elizabeth. I don't know if you have any discussions with education or other agencies where you can say, how do we negotiate what we give up?
Well, as a pediatrician, and my son was an athlete, and I was really impressed by, his football player, the team. They had a person that came in and taught them mindfulness. and how to manage their aggression sometimes and to calm down. And I think you do that type of behavioral intervention, maybe you don't need to pay for school resource officers. And what do they call the security things? Metal detectors. You know what I'm saying? The investments that we're making now are to address some of the behavioral issues that we're seeing. And maybe if we start on the front end and work more closely with parents and teach parents how to monitor and moderate better, then we don't have angry kids coming to school. So, I mean, that when I say this is a continuum, it's an everybody thing, but sometimes I think the investment, and it could be the pediatrician in me, that you start early, it's a much better investment than trying to rehab an adolescent or an adult.
Well, you saw the hearts you were getting there, so that people loved your comments.
Oh, my friends online.
A lot of people resonating with that. Yeah. Absolutely, absolutely. So very related question that Lynn Nichols gave us is that he's concerned about the fact that a lot of this work has been overly focused on interventions that can save money in the healthcare setting and generate healthcare savings, as opposed to looking at total social savings, including healthcare, but extending to these other sectors that we've been talking about, savings that may accrue to law enforcement, to the courts, to the educational system, as in Elizabeth's recent just example she just mentioned. So Lynn's question is kind of what is the state of the evidence about those flows, value flows into some of these other sectors beyond healthcare, savings to education, savings to law enforcement. What's our state of knowledge currently about those flows, and do we need more evidence on that front, in addition to evidence about how these strategies can save money in healthcare?
I don't want to keep jumping in first, but so Lynn, first of all, great question, Lynn. The hospital community benefit, my hope with all of this savings is that it's being reinvested, for the right thing. The intent was not to save the money just to pour back into the system. This intent was to save the money and target it to interventions that we know work. And so when I think about, for example, hospital community benefits, if you're saving money because you're keeping people who don't need to be in the ED out of there, then those investments should be targeted back into the community with housing and support systems and behavioral health programs and things, school-based programs. So, there's no restrictions on how your savings can be redirected. And that's what I was saying initially. It's not about asking for more money. It's about redirecting the funds that are currently available.
We have tools. Cost effectiveness analysis is one of those tools that can help us understand sort of optimal social policy issues. And I was getting my PhD in the 90s, and thereafter there was a book published, referred to as the Gold Book, because Martha Gold was the editor, about cost effectiveness. And what we saw in the decade or two after that book was published is an enthusiasm to create these cost effectiveness analysis models from academia, but whether it's a misunderstanding or a desire to get more nuanced information from healthcare systems. So I gave a talk once, and a person came up after the talk and said, "Todd, you present these data, you're always lying to me, because I do these things that you say are cost effective and I'm never saving money. I'm always spending money." And you could argue, one is that maybe it's a misunderstanding of what cost effectiveness is trying to do, but it's also a disconnect when we talk about social things and include things like criminal justice. We don't do enough talking about what does that cost effectiveness ratio include. And so for the person who is the healthcare leader, they felt very duped because they thought that they were going to be investing in this stuff and it was going to help them out, and they just felt like they were sinking money into it. So we've seen sort of a push back on that, and we've moved more to these budget impact analyses and so forth. I don't know where the pendulum's going to swing back. And so that's an interesting question about, like, how do we create these tools, use them, and then guide people to understand sort of the nuance in them? Because most of the time when I say even like randomized controlled trials, people glaze over. So I understand that it's easy for me to talk about research. I love doing it, but not everybody wants that level of detail.
Good points. Another question is asking about the connection between social determinants of health and the built environment, recognizing a lot of social needs relate or are deeply impacted by the built environment. And the question is about, to what extent are we engaging sectors that are focused on the built environment in this SDOH work, like urban planning, transportation, zoning, land use, et cetera. Any thoughts about ways of engaging those kind of sectors in this work?
So our work has been mostly an individual level, health-related social needs. And I think that there's a lot of work around health-related social needs right now, but the work really does need to go more towards the community level interventions. And in solving these individual needs, we have had, for example, just locally, just because of the way, to give an example, conversations with the bus companies about bus lines. But I think there has to be investments that are happening at both levels to see real health outcomes improving in the communities. And I think, one thing that folks were talking about earlier in the questions also was the role of the beneficiary, of the community member. And I think that including them in the work is very important, so that we can address both levels of needs, and then also make sure that at the end of the day, it's bringing value to the folks that are the beneficiaries.
Fantastic, very good points. Well, this has been a phenomenal discussion. Unfortunately, we are at the end of our time for today's panel. I want to make sure that we've got time to thank all 5 members of our panelists today, really for sharing with us their expertise and lessons learned in this space. Had a really good discussion, really heard about some exciting initiatives, and also quite a few remaining challenges and places where we need to continue to build evidence and build knowledge about the space. If we didn't get to your questions, we will be following up via email and to address those offline. And so for those of you who are with us, you can look out for follow-up email from our Systems for Action team. Also want to remind you that we've got forthcoming webinars, another entire panel devoted to this topic from a few different perspectives coming up. And encourage you to stay tuned to our website at systemsforaction.org for all the latest information about upcoming research in progress webinars and the great work happening through this program. So thank you again to all of our panelists, to Todd, Elena, Elizabeth, and Raj today. Thanks for attending today's session, and we look forward to staying in touch with all of you. Thank you.
Thank you.